So what we're going to do this evening, now I've had lots of requests from people for different things, and it's really difficult to know what to do first. But I thought this should really sort of take a logical order rather than skipping backwards and forwards. Hi, Karen. So I thought we'd start with the, if you like, the hardware stuff. So the surgery, the guidelines, the eating stuff, all of that over the next few weeks. And then in about, I don't know, 3 or 4 weeks time, depending on how quickly we go, I'm going to start doing some stuff on the head stuff more. So some emotional eating, craving control, looking at all this stuff up here, you know, that gets us every time. Hi, Karen. So, unfortunately for some of you who did come to the seminar in February, you have seen this before this evening. So if you would like to go, you are excused, although I'd love you to stay with us. That would be fabulous. But a lot of people have been asking about different types of surgery and what is new, what's coming up, particularly some people who are looking for revision surgery and those people that are looking for first-time surgery. Now, we recently had a seminar in Derby, and Dr Hruby came over to present at this seminar along with myself and a bariatric dietitian and a few others from the team. And he did a slot, if you like, on the different types of bariatric surgery. What is the most popular, how they all worked, how they actually were done, which, you know what, there was loads of stuff on there that even I didn't know, and I thought it was really, really useful. And also, you know, some of the up and coming things that are like, could be the gold standard for surgery in the future, and things that, you know, you're starting to do now. So, what I thought, rather than you listening to me garble on all night again, is that I would show you that video, hence the new software. Because what this means is, hopefully, you will be able to see this video of him talking, the man himself. So you can see Dr Hruby. Those of you that haven't seen him since your surgery, or those of you that have never met him, you'll be able to see what a lovely bloke he is, and you'll be able to see what his take is on all the different types of surgery. So I am going to try and show that live with you now. What I'd like you to do is, if you've got any questions at all, pop them in the comments, and either I'll stop it and try and answer the questions depending on how it goes, or if I can't answer the questions, I will ask him and I'll get him to either do another little tiny video to answer the question, or he can give me the information and I can get back to you. Or what I might do is answer them all at the end. We'll just see how it goes. But please, if you've got any questions, if you don't understand anything, let me know. Excuse me, my dinner's repeating on me. Sorry, you really didn't need to know that, did you? Right, okay. So without any further ado, I'm going to present Dr Martin Hruby. He is, for those of you who don't know, New Leaf's, I would say, main surgeon, as in that he's been with New Leaf the whole time, and that he does most of our surgery. That doesn't mean to say that Dr Chieni is any worse or anything. It's just that he doesn't do as much for us. Those of you who don't know who I am, my name is Amanda. I am the owner, Amanda Jane Duggan. I am the owner of New Leaf. I'm also a post-sleeve surgeon, a sleeve patient with Dr Hruby, and I am also emotional eating coach. I help people, particularly with bariatric surgery. I've been trained as a eating disorder therapist, and I help people with the mindset stuff. But I also help support you guys in your journey through weight loss surgery, right from the minute you think about it, all the way through surgery and beyond, years onwards. I'm there for you to help. So, okay, let's see what Dr H has got to say. Okay, I'm going to see if I can pop this video on now. Let's see if it works. Give me a thumbs up if it's working, please.
I will now speak about, let's say, the hardware, about the surgery. The hardware never works without software. And this I mean the support, pre-operative support, post-operative support, diet issue support, psychological support, all together should work. And I'm very happy that these services are improving within a New Leaf, and that you can really achieve the whole package. Yeah, and it's very important. Well, hardware. You know that the most often surgical procedures, bariatric surgical procedures, are sleeve gastric resection, gastric bypass. But speaking about gastric bypass, we must mention separately one anastomosis or mini gastric bypass. Then historically maybe gastric banding. We have gastric plication, and we have several malabsorptive procedures. And this is the international, International Federation for the Surgery of Obesity and Metabolic Surgery survey from 2016, and the numbers of relative numbers of procedures worldwide. In 2016, all over the world, there were some 700,000 bariatric operations performed. And 53% of all these procedures were sleeve resection, 30% gastric bypasses, and nearly 5% in this one was one anastomosis gastric bypass or mini gastric bypass. You can see the drop of gastric band, and my interpretation is that gastric band fulfilled her historical role and is finishing. Okay. I don't think it's a bad procedure. I'm thankful to gastric banding because in Czech Republic it was the gate opener to bariatric surgery. Yeah, because it was within the first days and months after the surgery, pretty safe operation with less early postoperative complications. But in long term, usually 70% of the patients after gastric band are reoperated, either with band removal or with another bariatric procedure usually. So, and the red line here, which ends at 0.5%, are malabsorptive procedures. Yeah? And you can see it's also decline here. So speaking about 2019 and about bariatric and metabolic surgery, we are speaking about two procedures: sleeve gastric resection and different types of gastric bypass. Yeah. There is no figure of gastric plication because gastric plication remains, let's say, experimental. The number, it is estimated that in 2016, maybe 5% of all bariatric procedures were plications. Last year on the World Congress in Dubai, 4 days event, 4 halls, from the morning till the evening, several hundreds of lectures. There was only one about gastric plication, and this was about complications and reoperations. Yeah. So gastric plications still has no official place within bariatric procedures. Yeah. So sleeve gastric resections, maybe you know something about it. Is considered to be a restrictive procedure. still we think that the main aim, or let's say act of this operation, is restriction. We decrease the volume of the stomach to approximately 80 to 120 cc. But of course, in this operation, we also recognize that we cause a lot of hormonal changes. Hormone ghrelin was already mentioned here, hormone of hunger. And this hormone is mostly produced in the part of the stomach that we remove. So it is it is proved that the levels of this hormone goes down after this operation. And our patients in 70% after the operation tell us that they feel really no hunger. Not all. Because of course, still there is a question: what is hunger? Yeah? Maybe Amanda will speak about it. What's hunger? Yeah? Mostly patients tell me, I hear noises. This is hunger. Yeah. So 70% feel no hunger. They report that. And of course, this helps to change in these eating behaviors and make these changes you need to do. But there's only one hormone changes, and we know that we cause a lot of other hormonal changes, and it is binded with the hormones of small intestine, and this is a group of more than 50 different hormones called altogether incretins. And very probably these changes then are responsible for the improvement of metabolic comorbidities like type 2 diabetes, high blood pressure, sleep apnea syndrome, polycystic ovary syndrome. Yeah? And this is really what interests us very much within the last years, because for instance, in case of type 2 diabetes, we observe 85% of patients after bariatric surgery with improvement or even resolution of type 2 diabetes. So, in this moment, surgeon treats type 2 diabetes. Please don't tell it to your internists and don't like this idea. And nearly the same reaction you can find in high blood pressure. Some 70% of patients after bariatric surgery need to withdraw the medication, decrease or even completely withdraw. And nearly the same numbers we can find in the obstructive sleep apnea syndrome. Do you know what is it? Mm-hmm. Okay. So, and I can't tell in numbers, but in women with PCOS, very often with problems to get pregnant, we have many babies now.
Lots of freebie babies.
And the women are coming and telling me that I'm responsible for that. So, again, I want to stress that this part, and this is called so-called metabolic surgery, is what's interesting me and other bariatric surgeons a lot in these days, and that's why even in the if so, the federation is not now called only International Federation for surgery of obesity, is added, and metabolic surgery, metabolic diseases. Okay, sleeve resections are nice because technically it's not very difficult procedure. Of course, as any other surgery, it has some rate of complications, and you know very well that I always tell you before the surgery that the most often is bleeding from the staple line on the stomach, because using some mechanical device to make a suture of the stomach wall brings this risk. And you also know that the most dangerous complication is so-called late leak. Fortunately, the number, or let's say the rate of this complication decreases below 1% in our series. In literature, it's around 2.5%. But this is a very dangerous and life-threatening complication. But these are, let's say, surgical complication. But this operation has also some negative side effects, which make some problems, and it is especially reflux problems. And from the statistics, we know that around 15% of patients after sleeve resection suffer with heartburn, with reflux problems, and need to use PPI, omeprazole and other, to decrease stomach juice acidity. And we have no any exact numbers now, but my estimation is that around 2% of all sleevers have such big problems with this, that it is necessary to make a surgical procedure, next surgical procedure, redo operation to solve this problem. And the resolution is conversion from sleeve resection to bypass. Bypass is a low pressure system. The anastomosis in between the small pouch and this intestine makes it easier to pass down, and so the regurgitation and reflux are a little bit lower and are manageable than with medication. Sleeve resection has gained large popularity within last years because of this, and because of course the follow-up after this operation is a little bit easier than after bypass operations. And of course these are all points of view considered by patients, considered by surgeons, and what's a little bit ironic that the first area where a sleeve become the first option was Northern America, United States and Canada, where gastric bypass was on the first place for many years before they developed this procedure. Why gastric bypass is the so-called gold standard of bariatric surgery. It was called gold standard because the number of gastric bypasses is still within the history the largest. Yeah? And again, it's thanks to Northern America, United States, because in this area there is the biggest number of bariatric procedures done. If I have mentioned that in 2016 there were some 700,000 procedures, half of them was done in Northern America. And of course there are some historical points of view and reasons for that. because in this area, for instance, a gastric band was not allowed for a long time. If we will go to the history, when they started with gastric band in the United States, the number of bands rised up and number of gastric bypasses went down. But of course this brings many new bands with many new complications, and in 2008 it brings the breakdown and decrease of use of gastric band. Roux gastric bypass was so that it's the most effective bariatric surgery because the short-term results were excellent 2-3 years after the surgery. And but the enthusiasm went a little bit down when the results after 5 and 10 years were published, because unfortunately through the time again we can find that there are patients who fail and regain weight again, like after any other procedure. The problem of gastric bypass is that in every patient we can't say what surgery was done, because gastric bypass is very variable procedure. I try to explain it, what I'm speaking about. Coming back to the sleeve resection, there is a pretty good consensus that in sleeve resections here is a pylorus, that we start the resection of the sleeve within some 2 to 4 centimeters from pylorus, and we are cutting the stomach on a tube inserted into the stomach, and this tube is in diameter of 32 to 42 French. It's a medical measurement. It's about, let's say, from 11 to 13 millimeters in diameter, so it doesn't play any big role. And then we stop some 1 centimeter from the angle of his, this is called angle of his. So you can do it 2 or 4 centimeters, you can use 11 or 13 millimeters in diameter tube, and you can do this here, not 1 centimeter, 1.5, but these are only small variations. But gastric bypass, first, small pouch of the bypass. There are authors that recommend the size of this pouch up to 60 millimeters. There are authors recommended 20 milliliters. 3 times difference. There are surgeons making transversal pouch, so it is cut here. There are authors making vertical pouch, short vertical pouch, but there are authors making long vertical pouch. There is one type called banded bypass, so this long vertical pouch with a band around the pouch, non-adjustable fixed band. So volume of the stomach or the pouch, so the size, the type, transversal or longitudinal, length, banded, non-banded, and we are still speaking about the first step. The second step is the epsilon plasty of the intestines. Yeah? So you can imagine that if my forearms are intestine, here are stomach, here is stomach, and here is bowel. So we cut the small intestine, the part from the stomach we put here, and this free arm we put on the new gastric pouch. So it's really Y shape. One arm of the Y is esophagus, small pouch, and this arm, so-called alimentary limb, and this is only to transport food. The second arm of the Y is the rest of the stomach, which remains in the abdomen, duodenum with biliary tract and pancreas, and the pink arm transport only gastric juice and pancreatic juice. Here they come together. The food comes together with the gastric juice, and only from here it could be absorbed. Well, and now what you can do? The really classic gastric bypass was with biliopancreatic limb of 40 centimeter and alimentary limb of 60 centimeters. This is not malabsorptive procedure. This is purely restrictive procedure, and I don't think that there is any surgeon in the world performing this way gastric bypass now. The most often type is that you make the alimentary limb 150 centimeters and the biliopancreatic limb 60 centimeters. There is some degree of malabsorption in this type of gastric bypass, but still many authors consider this type of gastric bypass simply restrictive procedure. What we can find that the malabsorption done by prolonging the biliopancreatic limb brings really a malabsorption, and the results are very close to the mini gastric bypass. But in such type, the biliary tract or limb is 200 centimeters, and the alimentary limbs remain around the 150. Yeah? And the most aggressive gastric bypass, called so distal bypass, brings, let's say, then we are not concerned about the alimentary limb, but we are concerned about the common limb. It means after junction of these two arms, and this should be around 150 centimeters, and the biliopancreatic limb remains 200 centimeters. Yeah? And you can imagine that many surgeons stays somewhere in between these three described possibilities. So, back, if you will take variations in a gastric pouch, if you will take variations in length of the limbs, then simply there are no two identical gastric bypasses in the world. Every clinic, every surgeon makes it his way. So this surgeon is doing the same all the time, or he knows what he is doing, but comparing 2 or 3 different clinics and results of gastric bypass is really tricky. Yeah? So this is the problem of gastric bypass. Well, we have spoken about reflux problems in sleeve resection, and that we saw that with conversion to gastric bypass, and maybe it comes to your mind. So why we are doing sleeve resections if there is such a risk there? Why we don't do gastric bypasses? Because gastric bypasses has also negative side effects and risks. It is said that around 5 to 10% patients after gastric bypass suffer from anastomotic ulcer. It means peptic ulcer in the anastomosis of the small gastric pouch and intestine. And it could bleed, it could perforate, cause huge problems and risks. And also you have heard about dumping syndrome. Whoever suffered dumping will never forget. Yeah? And this is not the worst, because after gastric bypasses you can also suffer with syndrome of postprandial hypoglycemia. I will try to translate it. You will have low blood sugar after meal. Oh, now you are looking at me and he's stupid. After meal, low blood sugar. Yeah. Again, this is because of what we have done with the intestines. In gastric bypass, the food is passing through the stomach into the intestine pretty fast, and especially if it is sugar in the meal. It provokes pancreas to produce a lot of insulin. It is, I can't find the word now. When it is too big, the reaction is too big, it's over.
Overwhelming.
Stimulates.
Oh, yeah. So there is too much insulin now in the blood, and it decreases the blood glucose. And it's really a dangerous situation, because if the blood glucose goes down, first the surroundings will see you as a drunken sailor, yeah, because the first signs are the same, like if you drink an alcohol. So you are disorientated, maybe aggressive, and so on. But going down, you can go to coma. Yeah. So, and it's very hard to treat such situations. So, what I want to say that no one of these surgeries are the best. All these surgery has pros, has cons, and has complications, has risks, has early complications, long-term complications, and no one is the gold standard. Also the results. We are speaking about conservative treatment that fail in 95% within 5 years, and I have told you that at least 30% of patients after bariatric surgery fail as well. And Scott has in his presentation that the long-term result is the loss of around 50% of excess weight loss. And the question is it enough? Still a lot of surgeons, or let's say doctors, and a lot of patients think that they have to lose more. So please give us something more effective procedure. And of course the best is such effective that I will have nothing to do more myself. You are speaking about it. Yeah. But what can we do? What can we offer? Of course there are the malabsorptive procedures. They were focused for solving this problem only decreasing absorption from intestine. And the very known is Professor Scopinaro from Italy and his biliopancreatic diversion. And the principle is nearly the same like with gastric bypass. So we make a bypass of a long part of the intestine, and we make a very long alimentary limb, very long biliopancreatic limb, and all these arms join only some 50 centimeters prior to bowel. In the large bowel, it doesn't resolve anything. So everything that resolves has these 50 centimeters. But this type of operation brings a lot of metabolic complications. Not only lack of vitamins, minerals and so on, but from time to time even lack of proteins. Yes, and these patients then were like the poor childs in Africa with the bellies full of water, simply said. Yeah. And there are also metabolic complications like liver necrosis and so on. Fatal complications, of course. And of course this type of surgery needs huge changes in the content of the diet, because the patients should stay on a high protein diet till the end of their life. And what we have learned, that patients are not able to stay on such type of diet economically, and of course by the nature of this type of diet it's not so good, because we need sugars. Yeah. And the worst thing in these malabsorptive procedures, where the patients stay on their high sugar diet, no proteins, because in such case they lose their own proteins, muscles, but with the sugars they get a lot of energy, because unfortunately sugars are absorbing everywhere. So they produce a lot of fat, and at the end there are bones and fat, and nothing in between. So really disaster. Therefore, as you have seen on the graph, this type of surgery goes down now 0.5%, because nobody wants to deal with such complications. But of course we need something more effective, like the standard gastric bypass, and some step in between is so-called single anastomosis jejunal bypass. It's a combination of sleeve resection. Then we cut the jejunum some 4-5 centimeters from the pylorus, and then we make an anastomosis with the intestine, like in mini gastric bypass, and the alimentary limb or common limb is in this type of surgery usually 300 centimeters. The first works were done with 250, but it brings such a high malabsorption that there are complications, so they prolong this. Well, that's good, but from my point of view, if we have troubles with sleeve resection with reflux, what will solve this procedure? Because you have sleeve, you have pylorus as a valve system, so you don't change anything on this. So we can expect the same rate of reflux problems like in standard sleeve. And what we will do if we will have such problems in this case? Yeah? So, this procedure was presented first maybe some 4 or 5 years ago. Still the number of procedures all those are low. Still we are again searching for the experience, and we will see. But it's a pretty tricky operation, needed good surgical skills. What could be some possibility is so-called SASI, single anastomosis sleeve ileal bypass. You can see again classic sleeve resection. You can see again anastomosis, but this anastomosis is done on the stomach before the pylorus. So first we think that we make a low pressure system, so it could improve reflux problems. Second, we add malabsorption because it is estimated, or approximately 80% of the food is going through the bypass, 20 through the natural way. Because 20% are going through the natural way, maybe we will have lesser dumping syndrome. Yeah? Because it is passing through the bypass, we hope we will have better glycemic response than in simple sleeve. Mm-hmm. And from my point of view, very important issue is that with this procedure we still have possibility to endoscopically examine or repair biliary tract. Because coming back to SADI, if you cut the duodenum, here is the pancreas and the biliary tract, and it is the same problem with gastric bypass. After these surgeries, you can't reach biliary tract endoscopically. So in any troubles with biliary tract, it's going for the open surgery. Yeah? But with SASI, we have the same situation like in standard sleeve resection, and endoscopically we can examine and treat everything. Yeah? But again, this is on the first steps of the road, as still the number of these procedures is very low. I was visiting Professor Gislason in Oslo, who is, let's say, father of this procedure. There is a group in I don't know, Doha or Dubai, cooperating with him, and the numbers are increasing. So we are waiting for the results, and we will see. But this could be a good option. So these are the ways in hardware. Well, but I have told you that we are focused on metabolic diseases, and we have already mentioned all these, and especially with the type 2 diabetes, it's a really long way, because that there is an improvement of glycemic levels after surgery. We have the first notes from last century, even in 1925, 1950s. In these years, there were reports about improving diabetes after, but these surgeries were done for cancers, for ulcers, and the metabolic effect was, let's say, unacceptable, or let's say not acceptable, but unexpected side effect. Okay? In 1955, this is the border, official border of starting with bariatric surgery, and of course, within this period, there were also reports about improving of diabetes, but in that time, we think that it is because of the weight lost, only because of the weight lost. Yeah? And the systematic explore of this was done within the last 10 years, and there are so far 12 or 13 surveys on the highest level of evidence that brings the results showing that surgical treatment of type 2 diabetes is much, much more effective than conservative treatment. And this leads in 2016 to a conclusion which was done at Diabetes Surgery Summit, second Diabetes Surgery Summit, and there was a panel of 70 specialists from all fields of medicine, not only surgeons, and these specialists make a joint statement about the treatment, algorithm of treatment of type 2 diabetes, and they make a conclusion that in this moment there is sufficient evidence that inclusion of metabolic surgery among anti-diabetic interventions is reasonable, and that the only problem is that healthcare regulators should introduce appropriate reimbursement policies, because everything is about money, of course. And the algorithm is now totally different compared with the history, because according to this algorithm, if you have patient with type 2 diabetes, obese, it means BMI above 30. If you have class 3 obesity, BMI above 40, in such case, you should refer this patient to metabolic surgery, not to treat him conservatively with insulin or anti-diabetics. Diabetes, class 3 surgery, class 3 obesity, surgery. This is really a breakthrough. Yeah? And what I was joking about the internists, because they don't like this idea, mostly, and it's a big problem to go through. But the results are clear. So maybe this is our near future. So let's do the surgery. Thank you for your attention.
Can you hear me? Give me a thumbs up or a heart if you can hear me. Fantastic. Okay, so I know that was quite long, but I didn't really know bits to cut out because I thought there was loads of it that was really interesting. I had no idea that there were so many different types of RNY bypass, for example. And I've worked in this for ages. So, yeah, I love him too, Lynn. He's amazing. Yeah, I thought it was really interesting. So I thought I'd just share it with you. Now, okay, so somebody said, what is a RAP? A RAP is commonly known as a gastric plication, commonly known as a gastric wrap. And basically what happens is they take your stomach, which is, the best way to explain it is a melon shape, and they fold it up like a tortilla and then sew it. So it changes your stomach from a melon shape to a banana shape, and it is sewn up. And it is the only purely restrictive procedure that New Leaf does, the gastric band used to be the same, as in restrictive, as in it only changes the amount of food you can eat. It doesn't have any metabolic changes like the others do. And the metabolic changes come when they, for example, with the sleeve, there is, as he mentioned earlier on in the video, because some of you may have joined later, please watch it all again because he explains all this. But with the sleeve, the ghrelin hormone is reduced, and in 70% of patients, because of that, they don't feel any hunger. For, I would say, between 6 and 12 months, it does come back because the body is a very clever thing. And of course, if we don't feel hunger, then we are going to die. So, the body readjusts itself. But within that golden 12 months, it's amazing. I remember walking past a patisserie shop in France, and I just looked at it and I thought, God, that's so pretty. I'd never described a cake as pretty before. Just didn't do it. And I didn't want it because I wasn't hungry. I just didn't feel any hunger. So that's one of the advantages of the sleeve. The wrap also, the plication, the wrap, because it is the stomach still left intact and they've not removed it as they do with the sleeve, it is much easier to stretch it. So therefore, what we have found over the past 5 or 6 years since we started doing the wrap is that many of our clients are coming back for revision surgery because they find that over the time that restriction is not enough and they're eating more and more. Now, that can happen with the sleeve as well, if people continually eat bigger portions, but it's much, much harder to stretch the sleeve, and it's likely to be a part of the sleeve. And at one time I'm going to come on one of these and explain to you about that, what it actually means to stretch the sleeve. But with the wrap, it can dilate the whole thing because it's just the stomach folded upon itself. So I would say that it's definitely not, on average. Now, we have some patients that do amazingly well with the wrap, but on average, it isn't as good weight loss as the sleeve and the bypass. The SACI, somebody just asked, Dominique, was it you? Yeah, I think it was. He's just been explaining that, so if you go back and have a look at that. But in a nutshell, it is a mixture of a sleeve and a bypass. So you have the very narrow tube of the sleeve, because I had to have a revision from my sleeve to an R&Y bypass because I was one of the very unfortunate ones that suffered from very severe reflux. About 10% of patients can do this. So basically, I had to go and have a revision, and I noticed almost straight away that my restriction was much less with the bypass than it was with the sleeve. I could eat more, which was quite frightening for me because I'd always been used to being able to eat very small portions and got used to using my sleeve to help me, and then I had to start weighing and measuring my food again and thinking about all that. But with the bypass, you've got the malabsorption, which means that a percentage of your food is not absorbed in the small intestine, the upper part of the small intestine, which means that the calories aren't absorbed. So let's say, for example, 30% of the calories that you eat are not absorbed. That's sort of how we put it, although it's more about minerals and vitamins and things. But the other thing that happens is that the gut bacteria changes and all sorts of other metabolic changes happen with the bypass that mean that the weight loss is usually higher, slightly higher than the sleeve over a 5-year period. Now, the SACI mixes the two up. What it does is it gives you the small tube of the sleeve with the restriction, but because it doesn't have this valve at the bottom, so the sleeve has a valve at the bottom, which if you think about it, when you start to eat, particularly protein, that valve goes and shuts. The easiest way, this is just layman's terms, putting it goes shut. And then you start to eat, and on top of that valve, and the food backs up. And if those of you that have had the sleeve will find that they start to get foamies, what they call foamies, because you can't put any more in. And you start to feel like a hard, solid lump here. When the restriction gets really here and you can't put any more in, it stops you from eating more. Okay. But what that can mean, because you've got this very small tube with this valve at the bottom, I'm going to move this so you can see me, with this valve at the bottom and this small tube, it means that that the restriction is very high, which also means that the food can back up and cause reflux. And, you can take tablets to get rid of this reflux, but in some percentage of people, that reflux is so severe, it used to wake me up in the middle of the night. It was really bad, in my throat. So I had to have the revision. And the revision meant that I can eat more. And some people, after the revision to a bypass from a sleeve, actually end up putting weight on. I need you to know this. Because they are so used to having that restriction of the sleeve, and even though they have the malabsorption of the bypass, there is something, we don't know why, but the second surgery, apart from something like the second metabolic surgery, let's say that, you only ever get that metabolic hit once. So you can't have a sleeve and get the metabolic hit of the sleeve, and then the bypass and get that metabolic hit. I didn't have that. I didn't have that, if you like, boost of metabolism, that not feeling hungry. I didn't have any dumping. I didn't have any of the shock things that I had after the first surgery. That's the only way I can explain it. So I had a bigger pouch, so I could eat more. I did have the bypass, but because I was more or less at goal weight, he hadn't made that limb very long. So have I lost any weight? Maybe half a stone more, maybe. It hasn't had a dramatic effect on my weight. Now, that's not why I didn't, okay? I didn't lose it because of that. I didn't have it to lose weight. I did it for the reflux, and it has more or less cured that. But the SASI, or the SASI, could be that one for people that want revision surgery. And I hope Michelle's talking about it now, so I'm sure she won't mind me mentioning this. She's the first one to have the SASI. We've got somebody else booked in. She was revising from a wrap, and previously it would have been wrap to sleeve, but this was better for Michelle for many reasons. But what it also gave you the sleeve, but it also gives you the malabsorption, so you've got the best of both worlds. But because you don't have malabsorb all of the food, 80% of it, 20% is going the normal way, which means that your stomach juices are going the normal way. Plus you don't have that valve for the reflux. And that means because 20% of it's going the normal way, there's not the possibility of suffering severe nutritional deficiencies, which can happen with a bypass. Particularly people don't take regular daily vitamins, calcium, vitamin D, B12. And people set off with all the best intentions, and then because you can't feel it straight away, they stop taking the vitamins, they miss a few, etc., etc. And that can cause real problems with pernicious anemia, vitamin deficiencies, bone problems if you're not careful. So we don't know yet. This SASI is a very new procedure, but it's not new in surgical terms because it's just a mixture of the two put together. So it makes sense that it is going to be really effective, particularly for longer term. And as Michelle says, she's losing it a little bit slower. She's still losing £2 a week. Now, £2 a week every week for a year, I've never did that before. But if she keeps it off, if it means she keeps it off, long term, that's amazing. And of course, Michelle, it is a second procedure, so you don't get the same metabolic hit. So I suppose it's a case of watch this space, really. Dr Hruby has started performing this now. He does it. It's the same price as the bypass, which for me I think is an amazing price because you're getting a bypass and a sleeve in one. I don't know whether he's going to put it up. I think he's keeping it a fairly reduced price at the moment so he can get a few people that go through it. He won't do it on everybody. He chooses the people that he thinks will get the best effect from it. Michelle has got a new page. Michelle, I don't know whether you want to put the link in there for your new page. She's got a new page all about the SASI bypass. I'm going to be helping Michelle on there. I'm sure she doesn't mind me saying that, if anybody wants any information about it. I've just realised how much I move my hands around. I've got to stop it. I'm going to sit on my hands. Like at school, they used to tell you to sit on your hands. So, yeah, I get a bit nervous when I do these. I don't like it. Get it easier. Okay, so that's the sassy, the sleeve, the wrap, and then there is the R&Y bypass, which, as he said, there's so many different types of it out there. It's very difficult to know. And this is why we can get varying degrees of efficiency between surgeons, because they all do it differently. They all do it different ways. So, are there any more questions for me for this evening? Because we've been on an hour. What I'm thinking is next week I am going to go through all the really important guidelines and tips for surgery, because so many of us forget them. So many of them forget how and what we need to be doing, what we need to be regularly thinking about. So many people say to me, oh, I'm going to go and do a 5-day pouch test. You don't need to do a 5-day pouch test. It will not help. I've tried it numerous times. All it does is make you very hungry. It might help you to get off the sugar because it's just a detox, but you don't need to go on liquids for that. And what it will do is it will help you to, just like if you had an upset stomach and you didn't eat for a few days, when you start eating again, you feel like your stomach shrunk. But very quickly, because you've restricted so many things, any weight you may have lost will go back on again. If you're struggling, what you need to do is think about going back to basics. And for those of you that haven't had surgery, what I'll do is be talking about the really important things you need to do when you've had your surgery to be as successful. As far as strategy is concerned, strategy and mindset, two different things, but the strategy is the physical, practical stuff. The mindset is the stuff, the head stuff, which we're going to be talking about in the next few weeks. But as far as strategy is concerned, I'm going to be talking about this next week. So, Dominique, you are confused with the difference between the mini gastric bypass and the SASI. Okay, the mini gastric bypass is a bypass, an R&Y bypass with one limb. And basically, it is a much simpler type of bypass. It has a similar results to the R&Y bypass, but it's not as complicated. However, the problem with the mini gastric bypass is that the actual malabsorption can be very, very high. And if you don't take regular vitamins and minerals, you can find that you get problems with pernicious anemia, which is lack of B12, anemia, and other vitamin and mineral deficiencies. And some people, even when they do take them, find that the malabsorption is very, very severe. Dumping syndrome can be very severe in the mini gastric bypass. It's got amazing results, but there are those complications. The SASI is like a mini gastric bypass, but it doesn't absorb all of the food. It doesn't malabsorb all of the food. It malabsorbs about 80%. So 20% is still going through the normal way and absorbing, which means that the chances of dumping, the chances of severe malnutrition are much reduced. Now, we don't know whether that will mean that the weight loss is much less than the mini gastric bypass. The chances are it will be negligibly less, and that's what we're hoping for. But it is going to be better than the sleeve. So, now the sleeve, 70 to 75% excess weight loss after the first year. The mini gastric bypass, probably about 80%. So if it's somewhere in between, it's not going to be that much different. But we don't know because it is new. But it is a sleeve with a bypass, but not all of it is bypass. Does that make more sense, Dominique? Have I answered your question? I hope so. If she's still there and she hasn't gone for a cup of tea or a glass of wine, which is probably what I'm going to do in a couple of minutes. I don't know whether you can still hear me because Dominique's not answered me. Did that make sense to everybody? Can you have some hearts, some thumbs up, something to let me know that you're still with me? Okay. I think you've all gone home. Did you accept? Brilliant. Thanks, Dominique. Glad that you understood it. That's fantastic. Lovely. So join me next week. I'll also be giving away a freebie next week. So I will be giving away a spreadsheet that you can use to, number one, there'll be one to track your progress, and number two, there will be ones that you can track whether you are sticking to your guidelines each day. So those of you that are struggling to keep on track a bit, it can keep you accountable. Those of you that have not started, it'd be really good to get into the habit of that, to have a look at it before you have your surgery. So if anybody's interested in surgery with New Leaf and Dr Hruby or Dr Czerny, or want some support from me, if you'd like some support with the head stuff or anything, let me know. I'm always here. You can find me on, I'll put it in the comments at the bottom, but you can find me on New Leaf weight loss page. I'll just pop that up for you, ws.co.uk, or Amanda Jane Duggan on Facebook. Lee, you're too late, Chuck. You'll have to go and watch the replay, but it's still lovely to see you, Lee. Missed you loads. Okay. I am going to upload it very quickly now so you can watch it. Lovely to see you all. Great to see you all as usual. Love ya. Bye.